Good morning, everybody. Welcome to another NIPMED tutorials, and today we'll be dealing with sickle cell disease. So, sickle cell disease and its variants are genetic disorders of mutant hemoglobins. The most common form found in North America is the homozygous HbS disease that was first described by Herrick in 19. Sickle cell disease, we know it's a relatively common disease in our area. The theory was that because of the continuous exposure to malaria, the human body had to adapt. So it mutated its hemoglobin chain so that to make the malaria parasite not to survive properly within this mutated hemoglobin chain. So in order to fight malaria, that was how the mutation occurred. And then now, this is where we are. When two people that have the recessive gene get married and give it to a homozygous individual, you get this. What happens is that there's a mutation that changes the mutation in beta gene that changes thymine for adenine. So we have GAG. So what this does is that normally glutamate, this is not glutamine, sorry, glutamate that is present in the sixth position gets replaced with valine. And we know glutamate is a negatively charged carboxyl group amino acid, while valine is branch amino acid that is not charged. So there's a problem in the normal hemoglobin structure due to this chemical change. So now under just needed conditions, hemoglobin S undergoes marked decrease in solubility, and there's increased viscosity, and the polymer forms at concentration exceeding 30 grams per dl. Okay, so in venous veins, we have low oxygen concentration where the blood is mostly deoxygenated. This hemoglobin S undergoes marked decrease in solubility. Okay, and its shapes begins to change. Now, this change, now repeated exposure to deoxygenated environments and repeated signaling will lead to a point in which the structure of the red blood cells changes permanently, making them to form sickles. Now, the clinical presentation is due to this abnormal shaped red blood cells that form sickles, highly viscous and are sticky. So, the gel-like form of hemoglobin is in equilibrium with lipid level form. Now, a number of factors influence this equilibrium. One is oxygen tension. Second is concentration of hemoglobin S. So those that have AS, the autosomal recessive, those that have the recessive gene have a certain concentration of hemoglobin S that is not enough to give them clinical presentation of sickle cell. Presence of other hemoglobins. Now fetus have hemoglobin F. So because of this hemoglobin F that is present in the fetus, remember hemoglobin F does not have a beta chain, it's actually alpha and gamma. So this protects the fetus from having these continuous repeated sickling incidents. So hemolysis is a constant finding in sickle cell. Why? Sickle cell patients mostly undergo intravascular hemolysis, but about 1/3 undergo intravascular hemolysis. Because of the abnormal shape of these cells, at the level of the splenic red pulp, they can't pass the sinusoidal splenic end capillaries. So because of that, the macrophages that are present in the pods of bile rods now goes and then eats them up, causing the hemolysis. Okay, so both the features of hemolysis and the sickle gives us certain clinical presentation, which is hemolytic anemia, painful vaso-occlusive crisis, and multiple organ damage with microinfarcts, including the heart, skeleton, spleen, central nervous system. These infarcts also due to the increased viscosity and the signaling of red blood cells in venous obstructing blood flow. So in several regions of Africa, the prevalence of sickle cell trait is as high as 30%. So 1 in 3 people. Sickle cell disease is present most commonly in blacks and is found in much less frequency in the Mediterranean and Middle Eastern population than equal male to female ratio. Clinical features. Presenting symptoms involve pain and anemia. But children also have a certain sickle cell habitus, which is bursting of the front and parietal bones due to hematopoiesis. From the repeated anemia and breaking down of red blood cells, hematopoiesis begins to undergo in the skull bones, leading to frontal bursting and parietal bone, the pressed nasal bridge, yellow discoloration because of jaundice, gonadopathy, abnormal teeth, distended abdomen, usually due to hepatosplenomegaly. Usually appear thin, have thin extremities. Now, patient may also present in crisis. Now, crisis could be vaso-occlusive, a bone pain crisis, aplastic crisis, hemolytic crisis, hyperhemolytic crisis, and acute sequestration crisis involving the spleen, and the spleen swallows the whole a large number of red blood cells. So another problem that occurs in infancy is hand-foot syndrome, which is also a form of dactylitis. It's actually a form of vaso-occlusive crisis involving the small joints of the hand and foot, causing painful joints on the dorsum of the hand and foot. Dactylitis. We also have acute chest syndrome. Acute chest syndrome is also a form of vaso-occlusive crisis, presenting with chest pain, fever, tachypnea, leukocytosis, hypoxia, and pulmonary infiltrates. Central nervous system is one of the most common devastating aspects of sickle cell disease. You see young children that already have a stroke presenting with hemiplegia, signs of cranial nerve deficits because of vaso-occlusive crisis occurring in the brain. And it's really sad. The heart is involved with chronic anemia and microinfarcts, so you have higher cardiac failure and dilated ventricles and atria. Now, when there is repeated infections of the joint bones and growth plates, it leads to aseptic necrosis, especially in the weight-bearing areas such as the femur. So you always hear there's present with aseptic necrosis to the head of the femur, causing severe chronic pain, disability, and it really affects them. And then kidneys also have a lot of presentation. One of them for kidneys one is isostenuria, in which the kidney loses ability to concentrate urine. Also, this from a form of papillary necrosis. It increases the development of renal cell carcinoma, renal medullary carcinoma, hematuria, proteinuria could affect the tubules, impairing the ability to absorb and secrete. So there will be problem with urine concentration, usually isostenuria, can lead to end-stage renal disease. Also, nephrotic syndrome is uncommon, but may occur. Maybe some paraorbital facial infarction leading to ptosis. Retinal vascular damage also can occur. Now, they have chronic vein ulcers. Now, these ulcers are usually venous ulcers because the aggregation and thickness of the blood vessels usually occurs at the venous. Okay, so it's going to impair circulation. Now, because there is impaired circulation, these ulcers don't heal properly. Okay, so a minor injury to the malleoli normally in a healthy person will heal properly, but because of the relatively poor blood supply and because of the formation of sickling and microinfarcts, especially at the level of the post-capillary venous, they have delayed wound healing. Then an infection occurs, we have this. Now, priapism is a serious complication, which is a prolonged, painful penile erection. Okay. Now, pregnancy, sickle cell in pregnancy is usually very, very difficult. It's painful for the woman because there is high rate of fetal loss due to spontaneous abortion, increased risk of placenta previa and placenta abruption also, and because of the excessive physiological demands caused with pregnancy, they are usually more prone to a lot of painful crises. And most of their infants are premature and have low birth weights. They can't really carry their babies to terms. So diagnosis is history, examination, and investigations. The diagnosis is hemoglobin and electrophoresis. You can also use blood film, which will show a lot of sickle cells and target cells. Radiograph of skull, chest, and lung bones will also show features of aseptic necrosis, dactylitis, frontal bursting, so on and so forth. So presence of sickle cells in the peripheral blood is a strong indicator. Notice what we call whole bodies. Normally, red blood cells don't contain nuclei. The nuclei are extruded prior to them forming reticulocytes. So when we see Howard bodies, there is a sign we call autosplenectomy, which is splenic. The spleen is no longer working properly because of repeated splenic occlusions, splenic infarction. Okay, it's also important to screen family members once damage is established because of the genetic disease. So you can see the sickle cells here, classic. So when we have red blood cells of different shapes, it's called poikilocytosis. Or red blood cells of different sizes, we have anisocytosis. So we can see both of them here, different shapes and different sizes. Treatment. So the goals of the treatment strategies is symptom control and management of complications. Okay, manage vaso-occlusive crisis, chronic pain syndrome, chronic hemolytic anemia, prevent and treatment infection, complication of breast organ damage, prevention of stroke, detection and treatment of pulmonary hypertension. People that have sickle cell disease, because of the splenic malfunctioning, they have difficulty fighting encapsulated bacteria. So this is caused by strep pneumonia, salmonella typhi, Neisseria meningitidis, H. influenza. They are more susceptible to this disease because they lack the ability to fight encapsulated bacteria. So the most common organism that's involved in strep pneumonia, that's involved in acute chest syndrome, is strep pneumonia. So you want to think if a sickle cell patient presents with acute chest syndrome, in addition to fluid resuscitation and oxygenation, you want to add antibiotics that covers strep pneumonia. Okay. Also, sickle cell patients are prone to osteomyelitis. The most common cause of osteomyelitis in sickle cell patients is Staph aureus, but also they are prone to salmonella osteomyelitis. So you want to give an agent that also covers salmonella, because salmonella is encapsulated and they can't fight it. They're also prone to cholecystitis because of the repeated hemolysis, formation of stones. So they are prone to both calculous cholecystitis caused by repeated hemolysis and acalculous cholecystitis caused by salmonella strains. Right? Surgical care is limited to treating disease complications. Skin graft for chronic leg ulcers, hip replacement. Now, resistant priapism. Normally, priapism you want to treat it with a vasodilator, such as something like sildenafil. You want to treat it with also an alpha blocker, such as phenylephrine. But when they are resistant to all these things, you might want to drain out the blood from the corpus cavernosus, from the pinna corpora, which is the corpus cavernosus. So cholecystectomy will be needed for gallstones, whether acute cholecystitis is present or not. Use either the classic abdominal incision or laparoscopy. In the mainstream care of people that have sickle cell, hydration is very, very important. Especially when you present with their crisis, you want to hydrate them. Okay? Then there may be need for other interventions like exchange blood transfusion, especially when they've had signs of when they've had stroke, or when they've had CNS involvement. Exchange blood transfusion might help even when they've had priapism. So in presence of severe vaso-occlusive crisis, exchange blood transfusion might help. Long-term management usually involves giving them folate supplements, proguanil, and might add hydroxyurea. Hydroxyurea has been shown to increase the number of HbF present. Since fetal hemoglobin do not have the beta globin chain, they do not have this form of abnormal sickling. Okay, all right. Some of the risk factors or triggers of crisis include infection, hypoxia, deficiency of 2,3-biphosphoglycerate. These are things that can trigger the patient developing any of the sickle cell crisis. And remember, infection is usually due to encapsulated organisms. Thank you very much.